Hello and welcome to the European Respiratory Society Guidelines in Focus video interview, a regular feature of the ERS Respiratory channel. The topic of this interview is recently published ERS EBMT Clinical Practice Guidelines on the treatment of pulmonary graft-versus-host disease in adults. My name is Federica Meloni and I am a respiratory disease physician, associate professor of respiratory disease at the University of Pavia, responsible for the Transplant Unit Center San Matteo Foundation, and I will lead the discussion today. Joining me in this discussion is Dr. Saskia Bos, who is a lung transplant consultant and works as a clinical research associate at Newcastle University, and as a lung transplant physician at the Freeman Hospital, and she is an early career co-chair of this published guidance. During this session, we will firstly hear the perspective of someone who's living with graft-versus-host disease resulting in bronchiolitis obliterans syndrome.
Hi, I'm Matthew Rutter. I'm a patient with graft-versus-host disease resulting in bronchiolitis obliterans syndrome. And then sort of about 6 months later, when I was sort of like recovering, I'd gone back to school at this point, and I was noticing more and more that I was struggling with my breathing. My classroom was on the 3rd floor of the school, and the only way to access that was via stairs. And I was noticing by the time that I reached the top of the stairs that I was getting significant breathlessness and taking a quite while to recover. I just hit the rock bottom, and then gradually over time, they put me on several quite intense therapies to try and remedy it. And it wasn't until like a few years later when I sort of saw my respiratory specialist. He kind of said that he would have liked to have thought it was the treatments that he gave me that made the difference, but he thought actually it was my ability to adapt because age was on my side. Throughout the course of the initial treatments and that sort of stuff, I've always had sort of lung function tests, which have been sort of like really essential. At one point, I was getting them almost weekly because of how bad it was. As time's gone on, monitoring has sort of died down. With respiratory, I tend to have currently like a yearly follow-up. And from an oncology, hematology point of view, for a long time that was yearly. I think actually it was a really great experience being involved in the task force. They were really interested to get the patient's perspective, and I was always very worried because I sometimes struggled to differentiate myself between Matt the physiologist and Matt the patient. And because the patient side was a while ago, the most recent stuff is the physiologist. But actually they were interested to hear both aspects, and it was really nice to, contribute both parts. I tried to sort of say as patient focused and thought, what did I feel about things from my experiences as a patient? And actually they were really keen to sort of get that across because they really wanted to make sure that the guidelines represented the patients. It wasn't just all about what the doctors thought, but they wanted to have the patient experiences put into it. And I think that really did help shape and put these guidelines much more sort of to a wider audience. And also it's something that really does take into account like the patient experience. I think from a healthcare professional point of view, then I think it's just an awareness that actually that, these patients have quite a lot going on, and actually, is quite difficult and a challenge for them. And so any support that you can give them is appreciated. And that's probably why taking on board patients' perspectives is so good. And I think in our group, we had a couple of different patients that had gone through it, and they'd got different sort of ages. So I was quite young when I had it. We had somebody else who was older. And so actually we had different perspectives on what was actually important to us as a patient. So as a younger patient, I wanted to get back to, you know, having exercise, good life, being out, whereas their perspective was actually they just wanted a really good quality of life, and that, you know, they didn't want to be burdened and that side of things. I think when, you know, speaking to patients about what treatments and that sort of thing, I think it needs to be explained what potential side effects there are, what might be the long-term problems, how it's going to make them feel at the time. All of these sort of things need to sort of be explained to the patient, especially if there's things that are more prominent than others. And I think probably most healthcare professionals already know this when they're doing the prescribing, but it's making sure like that the patient understands what's happening to them from a treatment point of view, and that they can make kind of an informed decision about it. Do they want to, you know, it may be a quicker treatment, but as a result of that, then they might have more side effects. I don't think this will be the end. I think there's probably still further to go. And it was such a great experience to actually see the other side. Like I've been doing a lot sort of professionally, but actually to sit on it from a patient perspective and give back from that point of view, it's something that I haven't really sort of explored much before, and actually was a really great experience. And it was nice to meet other people in similar positions as well. Even though I had this awful thing happen several years ago, I can see all of the positives that have come out from it, and the ability to sort of take that on and then feed that forward. I think that's what I'm probably sort of most proud of, the fact that actually it hasn't limited me, and I've been then able to sort of make differences elsewhere because of it.
Saskia, please tell us what made you decide on the subject of this guideline.
Yes, thank you. I will start in the field of hematology. So allogenic hematopoietic stem cell transplantation is a well-established and potentially curative treatment option for patients, well-selected patients with various malignancies, hematological malignancies, but also non-malignant diseases. And short-term survival has improved over time, but long-term survival still remains limited. And this is partly due to the development of chronic graft-versus-host disease, or GVHD. Within GVHD, pulmonary GVHD is a severe complication which occurs in about 5 to 14% of these patients, although most likely this is an underestimate because of underdiagnosis. And it is often associated with invalidating respiratory symptoms, and it can lead to respiratory insufficiency. And as such, it does have a significant impact on quality of life, long-term morbidity, and mortality. However, prevention and treatment of pulmonary GVHD are significant unmet needs, and the management of pulmonary GVHD remains very challenging, both in terms of diagnosis and treatment. There are only few therapeutic options available, and the use of these drugs remain mainly empirical. And there is currently no harmonized approach how to manage pulmonary manifestations of GVHD. And this is why we found it so important to summarize the data that we have available today on currently used drugs and their efficacy for pulmonary GVHD.
And so, what are the PICO questions that you look at in your guidelines?
So we wanted to cover three main aspects, namely pulmonary GVHD treatment, lung functional and radiological follow-up and supportive treatments, and we addressed these topics via 8 PICO questions and 2 narrative questions. And so the design of our PICO questions was in adults with lung chronic GVHD, phenotype Bos, should the drug X be used in addition to their conventional immunosuppressive regimen. So regarding the patient population, we focused on adults and patients with bronchiolitis obliterans syndrome. And the treatment options that we looked at are agents studied specifically for lung GVHD, Bos, but also used for chronic GVHD, and this included inhalation therapy with ICS-LABA, The typical FEM therapy, so combination of an inhaled corticosteroid with azithromycin and montelukast, imatinib, ibrutinib, the newer drugs ruxolitinib and belumosudil, and finally extracorporeal photopheresis and lung transplantation. In addition, we also had 2 narrative questions, so where the evidence was summarized in a narrative approach that covered lung functional and radiological follow-up and supportive treatments such as vaccinations, pulmonary rehabilitation, and long-term oxygen treatments.
And why did you only focus on bronchiolitis obliterans syndrome in GVHD and not on the restrictive form of GHD?
Yes, that is a very good question indeed. So it is very important to emphasize that there are 2 forms of pulmonary GVHD. You have the obstructive form, bronchiolitis obliterans syndrome, but also a restrictive form. And this is similar to what we see in chronic lung rejection, so-called chronic lung allograft dysfunction after lung transplantation. However, unlike after lung transplantation, restrictive pulmonary GVHD has not yet been recognized as an official pulmonary GVHD entity, and clear definitions of this entity are still lacking, making its recognition in daily practice more challenging. So because BOS is the best characterized and also the most common phenotype of pulmonary GVHD, we mainly focused on this phenotype for this guideline.
And what was the composition of your guidelines, and how did the process of the guideline proceed?
So this was a joint task force between the European Respiratory Society and the EBMT, the European Society for Blood and Marrow Transplantation. In addition to me as a junior chair, we also had Robin Vos from Belgium and Diana Stolz from Germany as chairs. And we are very grateful that we had a very diverse panel composition with a combination of hematologists and respiratory consultants. But in addition, we also had a specialized nurse clinician, a methodology team, and 2 patient representatives. And one of these patient representatives was Matthew Rutter, whose testimony you have just seen, who is also a respiratory physiologist, so that made it very interesting. And it was very helpful to have these patient perspectives and also to understand their different views on patient values. And so I'm very grateful to hear his positive feedback, as in my opinion, patient input should always be included in all guidelines and studies as much as feasible. And we also believe that in clinical practice, this interdisciplinary collaboration is of great importance to help this very specific patient population. So with regards to the guidelines, literature search in PubMed, Medline, and Cochrane was done by a librarian, after which the subgroups of our task force screened all articles, and then the data extraction and the grading, so the methodology part of the task force, was done by a methodology group, of which I was a part too, and then afterwards each subgroup summarized the data in an evidence to decision table, which was then discussed with the whole group before we tried to come to a conclusion and made a recommendation.
So I fully agree with the role of the patients because it's really crucial in many processes. And I just have another curiosity. Pulmonary GVHD is a quite specific complication of after stem cell transplantation. Did you find good evidence to address your PICO question in the literature?
Yeah, this was indeed quite a challenge. So we already discussed and agreed to include both BOS-specific studies, but also chronic GVHD studies with sub-analyses for pulmonary GVHD patients. But still, the number of studies that we could include, that we could use for the main evidence was low and varied between only 1 to 4 studies. And only for the PICO question on lung transplantation, there was more data available, and we had 9 studies as main evidence. So during this task force, we really noticed that BOS-specific studies are rare, along with the fact that most included studies were retrospectives in nature, and that also the number of BOS patients per study was often low. And then in addition, also the study populations were quite heterogeneous with, for example, a different timing of treatment administration. For example, you had patients who were treated in an early stage of the disease versus more late stage of the disease. And this can, of course, affect the treatment efficacy. And then on the other hand, studies often also use different study protocols, other treatment doses, etc. And also importantly, the endpoints quite often varied, and some studies use combined endpoints. For example, the overall response rate could be based on a combination of symptoms and lung function data, and not only the objective lung function data, which of course made comparison between the different studies quite challenging. And then also finally, we noticed that quality of life and patient-related outcomes were often not included, unfortunately, while our patient representatives considered overall survival, quality of life, and also the risk of side effects as very important outcomes to take into account, of course.
So there's a lot to do, still a lot to do in this field,
Absolutely.
right? So do you have any treatment-specific recommendation for these patients?
Yes, so regarding the outcomes, in general, the critical outcomes that we looked at were lung function, so the FEV1, overall survival, and then also the NIH lung score, which is a quite typical score they use in the field of hematology, and quality of life. And in addition, we also looked at important outcomes, which were exercise capacity, for which there was not usually no data available, impact on oral corticosteroid dose, and then also the incidence of pulmonary infections, serious side effects, serious adverse events, and malignancy or the relapse of the primary hematological disease. So in general, I can say that the use of ICS-LABA and FEM is supported in BOS patients. And in addition, there's also supportive data that extracorporeal phosphoresis can be used in patients with progressive disease, and that lung transplantation is a feasible option in well-selected patients with end-stage pulmonary GVHD. Imatinib and ibrutinib are in theory also possible treatment options, but their efficacy is less convincing, and especially the toxicity of ibrutinib should be balanced against the expected benefits. And therefore, we as a panel were not in favor of using ibrutinib, and we were not in favor nor against using imatinib in addition to conventional treatment. There was some promising data for the newer drugs, ruxolitinib, a JAK inhibitor, and also belumosudil, a ROCK inhibitor, in chronic GVHD. However, the data in pulmonary GVHD are at the moment still very scarce, and more data are needed before we can really support the use of these drugs in BOS patients. And then there were also some things that we considered important as a panel, such as the decision of the type of treatment should always be based on a shared decision-making with the patient, taking into account their preferences, the risk of side effects, and individual values. And then also to promote safe and effective treatment, the panel also considered it important that these drugs are prescribed by physicians who have the necessary expertise in their use and the possible side effects related to them. And then finally, during the task force, we also really noticed that there can be a lack of availability and or reimbursement in some countries. And this can, of course, complicate the implementation of certain agents in these countries, which is also something that we will have to work on in the future.
Could you give us an example of a specific case where the guideline should be used?
Yes, so before I give a case example, I think it is important to highlight that pulmonary GVHD can happen at any time after stem cell transplantation. And although we do see it quite early after transplantation, usually within the first years, we have also seen patients that developed pulmonary GVHD many years post-transplant. And so this case is the case of a 40-year-old female who developed BOS 1 year after transplantation and was already in stage 2 at the time of diagnosis. And this means an FEV1 between 40 and 59%. And this is something that unfortunately we do see quite often, that the median FEV1 is already around 50% at the time of diagnosis. And this is because routine lung function monitoring is often not implemented in all centers. And this has also been acknowledged by the community, and the NIH, the National Institute of Health, has now recommended routine lung function screening in all patients after allogeneic hematopoietic stem cell transplantation. If routine 3-monthly screening had been in place, this patient would probably have been diagnosed earlier when the lung function dropped below 75%. This patient also did have chronic GVHD of the skin and was also on immunosuppressive therapy with corticosteroids for this, and this is also quite typical. although pulmonary GVHD can be the sole manifestation, the majority of these patients do have chronic GVHD in other organs as well, and patients often already receive immunosuppressants for other chronic GVHD manifestations. And so unlike chronic lung allograft dysfunction after lung transplantation, it is important to emphasize that pulmonary GVHD is usually part of a broader disease spectrum. And so what we did is, at the time of the pulmonary GVHD diagnosis, we gave a pulse dose of corticosteroids, and then also we started a typical FEM therapy. And there was an initial improvement in lung function, but then the lung function started to decline steadily again, and treatment with ECP, extracorporeal photophoresis, was started. And this led to a stabilization in lung function for a few years. However, then the lung function started to drop gradually again further, and as this was a young person without significant comorbidities and otherwise well-controlled chronic GVHD, she was considered for lung transplantation and found eligible. And she finally then underwent lung transplantation 6 years after her stem cell transplantation, and she is still doing fine now 4 years post-transplant. So I think this case really nicely highlights some of the important aspects, such as the importance of routine pulmonary function testing to detect pulmonary GVHD as soon as possible to allow early intervention, the fact that pulmonary GVHD is usually part of a multisystemic disease, and also that with treatments such as with FEM therapy and with ECP, stabilization of lung function can be reached in some of the patients. What is also important is that patients should be referred for lung transplant assessment timely, as this might be a feasible option in well-selected patients with similar outcomes to what we see in patients transplanted for other indications. Unfortunately, we do not have currently a specific lung transplant criteria for these pulmonary GVHD patients. This is still something that needs to be established, including specific guidelines regarding patients with extrathoracic GVHD and also what the optimal timing is after stem cell transplantation. So the risk of hematological relapse is something that needs to be considered based on the patient's profile, and usually lung transplantation is not recommended the first 2 years after stem cell transplantation because of a higher risk of relapse. So regarding lung function monitoring, we suggest performing full lung function at the time of post-diagnosis, annually thereafter, and also at the time of disease progression, but with monitoring using spirometry, ideally every 3 months in between, or more frequently if the patient is clinically unstable. And then finally, regarding the supportive treatment options, this patient also received pulmonary rehabilitation both before and after lung transplantation, and she was also started on long-term oxygen therapy a couple of months before her lung transplant.
And going to the future, what do you think should be the next research priorities in this field, according to all what you have revised by now?
I think there is still a lot that we need to do indeed. So I think that was also one of the main outcomes of this guideline, to promote further research on the optimal treatment for patients with pulmonary GVHD. And larger studies are absolutely and urgently needed and should preferably be randomized in nature, specifically target BOS patients and use predefined similar endpoints to overcome some of the current limitations that we have related to the heterogeneity. And we would also like to encourage inclusion of newly diagnosed patients in clinical studies because data on first-line treatment is lacking at the moment. And so in this regard, also the use of umbrella and platform trials would be very valuable, as this would allow multiple treatments for BOS to be assessed at the same time and to move quickly between those treatment options based on new evidence that comes available. And hopefully these future research priorities will then help determine the most appropriate immunosuppressive regimen for BOS patients and help us create a treatment algorithm to really improve quality of patient care and to assist healthcare professionals in optimizing but also harmonizing pulmonary GVHD care.
Thank you. Thank you to you for sharing your experience with us and all your knowledge, and also in highlighting the new perspectives for research. Thank you, Saskia.
Well, thank you very much, Federica.